kind of a reminder of our overview on those. Congenital disorders sort of fall out into 4 categories. Chromosomal, this has to do with the chromosomes didn't separate correctly when the gamete formed. In other words, when the sperm cell or the egg cell formed, it didn't get both copies of all the chromosomes, or it got an extra. So we're going to see an example of that at the end of this little bit about Down syndrome. Genetic disorders, these usually refer to disorders of individual or parts of the genome, so parts of DNA. Might be as simple as a single change, like we see in sickle cell disease, or it might be a result of multiple changes in multiple places. But that's genetic. And then these last 2 present as congenital disorders. In other words, the baby has it at birth, but they're not due to any kind of genetic or chromosomal cause. And that's the developmental ones. We talked about those last time. These are caused by teratogens or substances or that can affect the baby's normal development. So like we talked about thalidomide, and also things like alcohol, cocaine, some of those. Because they affect how that embryo develops, they can cause congenital disorders. But they're not a genetic cause, it's more an environmental cause. And then the last one we're going to talk about today is birth trauma. And then we're going to look at an example. All right. So trauma can occur either in the perinatal or the pre-perinatal period. In other words, the damage can occur at birth as part of the birthing process. You know, birth is hard on the baby. You know, their heads get squished, they get squeezed pretty good. While the uterus is contracting, its blood supply drops off and then comes back. So it's a stressful experience for the babies. So damage can result if it's extreme. You know, probably the most famous version of that is cerebral palsy. And most cerebral palsies result from some degree of brain damage that occurred during the perinatal period. So either as part of the delivery process or as part of the labor process that went up to that. All right. And then, but these birth trauma can also occur pre-perinatal. In other words, not having anything to do with the labor or the delivery. So an example of this might be if mom had a heart attack, for example. The baby might suffer some loss of blood flow because of that traumatic event. Or mom lost a lot of blood in some other reason, you know, from a bad injury or a car crash or things like that. Depending on when that trauma occurred, that's going to determine how significant the deficits are and what kind of deficits those are going to be. The earlier the trauma, the more profound usually the congenital abnormalities that we see. And then very rarely the baby itself can have problems like a blood clot, stroke, a bleed, you know, particularly if they have a blood disorder or something like that. So the very same things that can happen to an adult can happen to a baby as a fetus in development. Now, they're very, very rare that those things happen, but that too can lead to cerebral palsy, for example. If the baby had a stroke early on before birth, it's going to look like brain damage, and most of the time people will say, oh, it must have been some damage in the perinatal period, when in reality it may have been a stroke that occurred, you know, at the 4th month of gestation. All right. So when we're looking at congenital disorders, we have a number of diagnostic tools that we can use. One of the most common that's done is a karyotype. And what a karyotype is, it is literally just a high-quality picture of the chromosomes. During one part of meiosis, when the cell is dividing, and during mitosis as well, the chromosomes separate from the nucleus and actually form up into their 23 pairs. And if you take a picture of the cell at that time, you can create a sort of grid of the different chromosomes, and you can check for number, you can check for shape. And in these days, we can do this with very high resolution. we can actually label parts of chromosomes to see if all of the right parts are there, basically. So that one's easy. But you need to have baby cells to do it. Easy to do after the baby is born, but before the baby is born, it's somewhat challenging to get fetal cells without doing damage to the fetus. So the two primary ways that that's done is amniocentesis, where some amniotic fluid is drawn off from the uterus. We spin it down, and oftentimes we're able to find enough fetal cells in there to then grow in a culture and then do a karyotype, if we're concerned about something like Down syndrome, for example. Another more invasive procedure, but one that can be done earlier, is the chorionic villus sampling. And this is where the surgeon actually goes in and takes a little piece of the baby's placenta. And since the baby makes the placenta, it's not mom that makes the placenta, it's the baby's work, it's all the baby's cells. So that is another way of grabbing some fetal cells. But because it's tampering with the placenta, the risk to the baby is higher. So typically amniocentesis is done first, and then if we need to get information earlier in the pregnancy, we can go to chorionic villus sampling. And then there are some other tests to look at the potential for congenital disorders. So as part of prenatal care, there are a number of tests, blood tests, that can be done on mom to at least get some sense about the health of the baby. The most common one is called the triple screen. And I'm sorry, but I don't know what the three things are. I just know that Down syndrome is one of them, and spina bifida is another. But it's a blood test that can help to identify if there's something wrong. The problem is it's not a great test, because a negative triple screen doesn't mean your baby doesn't have Down syndrome or spina bifida. A positive test also doesn't mean that the baby for sure has that. It needs confirmatory testing. So some people are adamant about the triple screen in prenatal care, and some doctors think it's a bad idea, because all it does is create stress for mom if there is either a positive or negative result that ends up being false positive. The other issue that comes up ethically about the triple screen is, well, what if it's positive? Is the woman willing to end the pregnancy is another thing. Because if not, then you have to ask the question, well, why do the test then if it's not going to change anything? So it's one of those that will come up in ethics discussions sometimes, the triple screen test. Some other tools for assessing congenital disorders. Today we can actually test the DNA itself, which is relatively new technology. We haven't been doing that for more than about 40 years. But as we learn more and more about the genome, we're finding more and more regions of DNA that we can test for different disorders. Typically, these are only done if there's a strong family history for a genetic disorder. So like sickle cell disease, Tay-Sachs disease, which we're not going to talk about, but it's found in certain sects of Jews. Cystic fibrosis is another one that tends to run in families. So genetic testing. And then neonatal testing. This we do on all babies, unless mom has signed away, basically saying that she's not going to do it. So, because this is a state requirement. And what these neonatal tests are, in the OB department, it seems like a really simple thing. You prick the baby's finger, and then you put some spots of blood on a little paper card, and you mail it to the state. Doesn't seem like a big deal. But when they get that card, they run anywhere from 12 to 100 different tests on that blood, looking for genetic disorders for which there's an available treatment. So the most common ones, and the ones that come up on board exams most often, are PKU and hypothyroidism. So PKU is phenylketonuria, and basically it's the patients are lacking an enzyme, which means that they can't break down certain amino acids. And their phenylketones end up getting very elevated, and that causes brain damage, among other things. Hypothyroidism is not having enough thyroid around. Both of these are very easily treated. PKU is treatable by not giving those amino acids that they can't metabolize. Hypothyroidism is treatable because we can give the baby thyroid hormone and get them back up to normal. And most of the tests that are done as part of this state screen are like that, where there's a simple, easy treatment that can result in much less damage to the baby. So, for example, before we started testing for PKU, there were huge numbers of babies that would go on to mental retardation because those phenylketones had destroyed parts of their brain. Today, we hardly see that at all. So these are very effective public health tests. You know, they improve the quality of life for patients that would otherwise have had significant problems. All right. And then for a few specific genetic diseases, there's neonatal DNA testing. So this is confirmatory testing to make sure that the baby either does or does not have one of these common genetic diseases, like cystic fibrosis, like sickle cell disease. If those are in the family, we'll send blood for DNA testing on that. In some states, cystic fibrosis testing and sickle cell testing are actually part of the state screen, the neonatal screening. They're adding tests to the neonatal battery all the time. So when you work with moms that are uncomfortable having their babies finger pricked for this funny state blood test, it's not any conspiracy theory stuff. They're not collecting people's DNA. They're not, doing blood cross-matching and typing for organ donation or organ banking. All they're doing is testing for things that would cause the baby harm. So it's probably the cheapest, because it's free for the moms, because the state pays for it, and most effective of all the blood tests we do in newborns. All right. So as I said, now we can test DNA. And one of the things that this is bringing up is whole new ethical discussions, because we know more about many genetic diseases than we know how to treat them. So we can often identify that a person has a disease even before they're having any symptoms of it, but there's no way to change the course of that disease because we don't have any treatment options. So one of the ethical debates is, should these genetic tests be done? If it won't change medical care and all it will do is label the person as having a disease, isn't that just a problem and not a benefit? Because, for example, insurance companies, if they were to find out that you're positive for Parkinson's disease, are not going to want to insure you because at some point you're going to cost them huge amounts of money. So the jury is still out about when genetic testing should be done, how it should be done, at what ages, all those kinds of things. Because when you find out, for example, that an uncle, for example, has been diagnosed with Parkinson's disease, a lot of times everybody in the family wants to know if they're going to have that same disease. And it depends on the doctor as to whether or not they'll run those genetic tests that you're interested in. And then, of course, we know that DNA, because it's unique to everybody, is used by law enforcement for its identification ability. All right. So an example. So one of the chromosomal disorders, and the most common of the chromosomal disorders, as well as probably the most common genetic disorder that you'll hear a lot about. In other words, it's a problem with genes, but it's at the chromosomal level. And that's Down syndrome, where they have, instead of 2 chromosome 21s, they have 3. So it's a constellation of symptoms. Important to note that everybody with Down syndrome is different, though. While you see common characteristics, no one Down syndrome's patient's group of symptoms or signs and findings is going to be the same as another. There are mild forms, there are severe forms. It has a lot of diversity to it. It's known to, the risk to have a baby with Down syndrome is known to increase with maternal age. So the numbers your book gives, at age 30 it's a 1 in 1,000 risk, but at age 40, only 10 years later, it's 10 times the risk, 1 in 100. So typically, anytime there's a pregnancy in a woman over 40, that's considered a high-risk pregnancy, and one of the reasons for that is the increasing incidence of Down syndrome as mom gets older. The triple screen is the earliest test you can do. If it's positive, then they'll do an amniocentesis to culture those cells and look for trisomy 21. Many of the findings of Down syndrome, the characteristics you can see on ultrasound, but ultimately it's the diagnosis is made at birth, unless it's made by amniocentesis, where you can very clearly see that the baby has these characteristics. So here's the list. Small head with a flat face, that's Down syndrome. Eyes are slanted and narrow, slit-like. If you can get their eyes open, which is really hard in Down syndrome babies because they're so narrow and their faces are kind of fat. Their iris has what's called brush field spots. So around the iris, the iris is the colored part of the eye, there's a circle of spots. Now, I don't know where those come from, but they're there. The mouth tends to hang open even when they're asleep, and their tongue kind of sticks out. And we call this macroglossia, but it's really two things. It's their mouth is small and their tongue is large, so it's like their tongue doesn't fit in their mouth, so their tongue sticks out. I've got a picture here in a minute. A high arched palate, so when the baby's crying, you can see instead of the palate in the back having a nice smooth thing like that, their palates go like this. They have kind of a peak, like a Gothic church window does. The hands are small, and this is a classic one. This is board exam quality stuff. So single palmar crease. So everybody look at their hands. And we have two lines that go across from thumb towards pinky. In the Down syndrome baby, they have just one palmar crease that goes across. And you can see that in the infant. So it's a classic sign for Down syndrome. Now, do all people with a single palmar crease have Down syndrome? No. But if you see single palmar crease on a board exam, it's probably going to be Down syndrome. Big space between the big toe and the second toe. So in other words, their feet look more like a hand, because there's more space between the fingers and toes. The fifth fingers are usually very short, which kind of stands out. And then they're hypotonic. We call them floppy babies. And there are lots of reasons to have a floppy baby, a baby that doesn't have much muscle tone. But Down syndrome, their joints are loose, and neurologically they're they're not as active as most babies are, so they tend to be floppy. You pick them up and their arms and legs fall out. Normally a baby will kind of hold its own position. So floppy babies. One thing we have to be careful of is they have neck problems, as in the bones of the spine at the cervical vertebrae don't always form correctly, so they may have instability in the head. So one of the first things that is done is, they're mini backboarded and they're taken for x-ray, or you bring the x-ray there to make sure that the neck bones, that the head isn't going to sever the spinal cord. And then ears are small, and just like the front of their head is flat, the back of their head is flat too. So here are some pictures. So you can see a round, flat face with narrow eyes. You can see how the mouth is kind of open, and you can see the tongue sort of sticking out. That's that macroglossia. Here's that single palmar crease. So compared to us, that have two parallel lines, their two lines kind of join in the middle here. Here's that big space between the fifth, or the big toe and the second toe. Small ears, flat occiput, or back of the head. Here are those brush field spots. Do you see them? Do they project very well? Not really. But you see there are little dots here. And then the last one is, see how short the fifth digit is compared to its neighbor? So these are classic physical findings. Now remember, no two babies with Down syndrome are exactly alike. So some will have some of these, but not all of these. So if it's starting to look to you like it might be a Down syndrome baby, it's time to do a karyotype to be sure. But the face is classic. You know, you see one infant with this, you can spot them every time. All right. Not all the problems are on the outside. In fact, the most significant and severe problems have nothing to do with their little physical differences. They have to do with the fact that Down syndrome comes with a whole constellation of medical problems. So they're developmentally delayed. This one is practically across the board. Even mild Down syndrome cases that don't have many other problems are going to have some degree of developmental delay. Now, with improved programs for early intervention, the how delayed they'll be as an adult has gotten better. You know, because we found that if we stimulate the parts of the brain early on, we can actually improve some of the outcomes for developmental delay. So that has been better, but they still never reach normal adult intelligence. As they get older, sexual development is either delayed or incomplete. They never really get through adolescence, not physically or mentally in many ways. So even a Down syndrome patient who's 40 years old, in many ways is going to act a lot like a teenager would act. Has anybody worked with Down syndrome patients in here? Just one. But that's a common one. Let's see. And there are lots of medical problems. So visual problems, they're often born with cataracts, and they often they're profoundly myopic, so they need glasses early on. Hearing problems, digestive tract problems, celiac disease, which we'll talk more about in another chapter, is common in Down syndrome. That's where certain kinds of wheat create diarrhea and malabsorption. Their immune system is poor, so it makes them at risk for infections. They have a high risk of developing leukemia. And circle this one, congenital heart problems. Because your Down syndrome patient on your board exam will probably have a congenital heart problem. And that's because it's one of the most severe outcomes of Down syndrome. What can kill a Down syndrome baby in the first 2 months of life? Congenital heart disease. So the most common one is the tetralogy of Fallot, which we're not going to get into now. We'll talk about it when we get to the heart. But it's tetralogy is 4, so it's 4 different malformations all in the same heart. And sometimes in the Down syndrome patient that doesn't have a lot of the physical characteristics, every child with tetralogy of Fallot gets tested for Down syndrome anyway, because the relationship is so strong between those two. And then nowadays, because of the ability to do heart surgery in kids, the ability to fix a lot of these problems which would have killed the Down syndrome patient decades ago, now Down syndrome patients can live to be 30, 40, even 50 years old. And as they get older, what we see is almost across the board the development of Alzheimer's disease, very early in life for that disease. But for the Down syndrome patient, who really probably only has a maximum lifespan of about 50 years, they may start developing Alzheimer's symptoms at even 30. So those two things go together. Again, as much as we know about Down syndrome, we don't know why these things happen. We only know that they happen. And we're always learning more about that. All right, so let's do a question here real quick. I'm going to send you the student number question first. So if you're not logged in yet, remember we're in room 4233. 42. And I've got 12 in the room. Not working.
I'm just waiting for you to print out. It's got the right room.
Have you tried logging out, logging back in?
Log out, back in.
Can you see 10?
Huh?
Can you see 10?
Yes. I have 1, 2, 3, 4, 6, 8, 11, 12, 13, and 10.
You don't have 14?
Huh?
You don't have 14?
Is it working?
But you don't have 14?
I do now. My screen updates. It's not automatic. It goes like this. And there, I just got number 1. Is that you?
It's not showing. It's supposed to be me.
Well, I got your number 1.
He didn't release the question yet.
Oh.
This for the student number question. All right, that's everybody. Okay, let's go to the question. Which of the following statements regarding Down syndrome is true? And now I have to send that. Okay. I think that's everybody. And good, most of you got that. A, the typical physical characteristics are present at birth. There's not very many diseases where the diagnosis is made by sight, but this is one of them. You know, it's one of the reasons why the doctors and nurses in the OB ward do very careful physical exams of newborns, is you never know what you're going to find. Yeah?
When you're pregnant, is there any way or anything that leads a physician to suspect that you're going to have a baby with Down syndrome, or no?
Not except for the screenings. If your triple screen is high, for Down syndrome, it's the AFP, the alpha-fetoprotein.
Yes.
If that's high, then they'll do an ultrasound, and if that still suggests, then they'll do an amniocentesis, yeah. But no, there's nothing in mom's pregnancy that's going to give you any clue. They're normal pregnancies.
So since they really don't reach anything past adolescence, are they able to reproduce?
They are physically, but most don't. And I believe, I don't know for sure, but I believe they're infertile. But
It's not like it's passed down.
it would be, but I'm not sure that, I'd have to look it up. I don't remember if they're fertile or not. But so few of them ever reach independent living that it doesn't come up. All right. And there was something else I wanted to talk about. Okay, so D, don't get tricked on this one. Just because the risk goes up after age 35, a woman of any age can have Down syndrome baby. Even adolescents can. So don't get tricked into thinking that. It's just the risk goes up the older mom is. All right. So blood tests are primarily performed on neonates in order to do which of those things? And many of you would-be nurses are going to do these, the little state card. What do they call them? Anybody know? No. The state screen is what we always call them.
It wasn't in my nursing that they did this.
The little state cards? You're kidding.
When we do it in OB, they just call it the PKU test, and then I think the parent signs and everything else is just included with it.
Yeah.
Not that they don't know what they're getting into, but that's what they usually.
Well, they just don't know the bargain they're getting. I mean, because these tests, if you were to run them, if you were to order all these tests, it would cost you thousands of dollars. But because the state does so many of them, they've got a factory of a lab that does these things. They can knock them out, for free. So it's great. All right, so the answer there is B. Because why do we do these tests? We're looking for things that we can alter the course of that disease with something easy. So most of what we're testing for are metabolic abnormalities. In other words, missing enzymes, missing proteins that cause something to build up or cause something to become toxic. And by controlling things like diet and simple medications, we can prevent what would have been the disease caused by that genetic disorder. So no, not usually surgical. There aren't very many DNA tests that are done, and it really doesn't have anything to do with infection. All right, I think that's it. Okay, good. So that's congenital abnormalities. lined out there. And now we've got a couple of little simple chapters to get through. At least I think they're simple ones. All right. And like many of these, compared to what's online, I've thrown some slides out for the sake of time. All right, so diseases associated with adolescence. So adolescence obviously is the time between childhood and adulthood. It has never very firm numbers associated with it, in other words, ages. And that's because there's a huge variation between when do people enter adolescence. You know, it can range from age 8 all the way up to age 14. And at the other end of it, people can be done at 16, or they may not be done until 25. So there's a huge range there. And while obesity is certainly not a disease of the adolescent, your book brings it up in this chapter because more and more children are becoming obese at earlier and earlier ages. And because obesity carries with it risk of all kinds of what used to be considered adult diseases like type 2 diabetes, hypertension, high cholesterol and lipids. Since there's more obese adolescents, we're seeing these adult diseases more frequently in older children. Now, why is that? Probably decrease in exercise. You know, parents are more fearful to have their kids outside, you know, riding their bikes, playing around than they used to. So kids spend more time inside, which means less exercise. High-fat diet, high carbohydrate food and drinks. I think some of this in the country is changing. You know, it got real bad, and now I think it's getting better in terms of what's available for kids to eat. But we define or diagnose obesity by body mass index. And this is just a calculation that compares your weight to your height. Technically, it's your weight to your surface area, and then compares you to the rest of whatever group, which usually we compare Americans to Americans. So 95th percentile, if you have a BMI higher than 95% of people, that's obese, and then 85 to 95%, that's at risk. So one of the things that comes with obesity is this relatively new diagnosis, or at least identification, of metabolic syndrome. Many, many obese people, adolescent or adults, have this syndrome, which includes a number of common qualities. So one is significant abdominal fat mass. So one of the classic descriptions is you see metabolic syndrome in pear-shaped people less often than you see it in apple-shaped people. So that's that significant abdominal fat mass. So they're thin on top, heavy around the middle. Along with that, we've seen changes in glucose metabolism, which leads to type 2 diabetes. We see changes in lipoprotein metabolism, so your HDLs and your LDLs. That causes high triglycerides, high cholesterol, which then in turn are a risk factor for atherosclerosis and heart disease. And then in addition, we often see hypertension. The more weight a person has, the more blood vessels have to carry or have to get to all the different places, which is probably one reason. In young people, 1 to 4% of children and adolescents have this syndrome, the whole group there, but 49% in clinically obese young people. So that's huge. That's half of the clinically obese adolescents are going to have this metabolic syndrome. The underlying cause is really not completely described, but one of the effects is adipose tissue releases insulin antagonists. An antagonist is a blocker, so it's an insulin blocker. This causes insulin resistance, which then leads to high blood sugar because the glucose can't get into the cells. And then we get the complications of type 2 diabetes, which are cardiovascular disease, hypertension, heart failure, kidney failure, those things. The earlier the obesity starts, the earlier the metabolic syndrome starts, and the earlier the complications of metabolic syndrome result in death. So one of the relatively new things that we do in adolescent, like school physical exams, is we talk about weight and we talk about diet and exercise to try to reduce the numbers here of the metabolic syndrome. All right, so that's one thing that we see. During adolescence, there's a growth spurt. We all know that. We all experienced it. And because those long bones grow quite quickly, basically the adolescent goes from a child physique to an adult physique in just about 4 or 5 years. So as they take on that adult shape, we can start to see some of the postural abnormalities is when these first occur. So there's 3: kyphosis, lordosis, and scoliosis. All right, so kyphosis is this middle one, and it would be humpback or hunchback. And what you can see is the thoracic curvature is greater, and the lumbar curvature is greater too. So basically, the normal sort of S-shaped spine becomes very S-shaped. So we have the kyphosis is this part right here. Can be caused by posture. If you've ever had somebody tell you to sit up straight, it's because they're trying to prevent kyphosis from developing early on. Old people get this as their bones become more brittle. Oftentimes the vertebrae of the spine sort of become wedge-shaped and they get hunched over. Okay. The other one is lordosis. Lordosis is an increased lumbar curvature. So kyphosis is thoracic, sticks out. Lordosis is lumbar, and it sticks in. In a minute, we're going to talk about some pregnancy things, and we'll see that in pregnancy, lordosis is normal as the center of gravity shifts. But in the teenager, you shouldn't see this profound curvature on the inside. So they call this one sway back. Poor posture again. Obesity can cause this, particularly if you're heavy up top. It's a lot of weight put on the lumbar spine, and one of the directions it can go is it can kind of bow inward like this. And then the more famous of the 3 postural, or not postural, but musculoskeletal disorders is scoliosis. So scoliosis is a lateral curvature. So if, arms, legs, in scoliosis, the curvature we're talking about goes like this. So it's to the either to the left or right. 2 versions, the structural and the functional. So the structural scoliosis is because of a bone problem. So either the vertebrae are not sitting right on top of each other, or one is curved, a malformed rib, malformed vertebrae. 80% of these are idiopathic. In other words, we have no idea why they occurred. It does tend to run in families, and it's much more common in women than it is in men. So if mom had scoliosis, chances are daughter's going to have scoliosis too. All right. And then functional scoliosis, you could also call it secondary scoliosis. In other words, it's a lateral curvature due to something else that doesn't have anything to do with the spine or the trunk. So for example, an unequal leg length. Say at age 4, somebody had a femur fracture of the growth plate. So the one leg didn't grow as much as the other. That can cause an unequal leg length, which is then, as the body tries to stay straight, is going to result in a lateral curvature to correct that. Mild postural scoliosis can be corrected with exercises. One of the new ways of dealing with scoliosis is through a kind of physical therapy where you strengthen the back muscles, and the back muscles then help to pull that spine back into the shape that it's supposed to be in. Or bracing. Anybody in here have a scoliosis brace ever? No? Sometimes. It's common enough in young women that you sometimes will, you hear about it anyway. The more severe forms, they actually have to go in and fix it. And anytime you have to go into the spine to fix something, it's major surgery because there's all kinds of muscles to even get to the spine. And then the instrumentation, on x-ray, it looks almost brutal because there'll be screws and pins and plates and rods and all kinds of stuff in there to get that spine into the alignment that they're looking for.
postural scoliosis fit more into functional or structural?
Postural would be a functional scoliosis, yeah. So what does that look like? Here's the normal spine, that's nice and straight. Mild scoliosis, the hips and shoulders are level. You know, there's no angle here or here, but when you look at the back, you can see this curvature. And then in severe scoliosis, you'll have uneven shoulders and or uneven hips because you've got this major curve here. Typically, when we go to look for this, we have the patient bend over, usually with, clothed from here on down. And the reason for that is when they bend over, you can see the ribs on one side and not the other. So it increases your sensitivity by sight of identifying those scoliosis.
So because women are just more common to have it, that's why that if like a dad has it, it's less common for his child to get it?
Yes, because it's so much more prevalent in girls than it is in boys. I mean, we still check boys, but usually girls get checked a number of different times. Like they'll get checked as part of their school physical. They'll get checked by the nurse at school because it's so much more common. And you want to catch it early. The reason we really look for it in adolescence is we can fix it then without surgery. If you get to this, you're going to be laid out on back surgery as they try to fix it. All right. Oh, we just talked about that. We're going to skip that one. Okay. Osteomyelitis. Again, this chapter is a little weird because none of these disorders, except maybe the last one we just talked about, are specifically about adolescence. Osteomyelitis is simply an infection of bone. Now, because it's usually associated with trauma, and because most trauma occurs, not surprisingly, none of you will think, to young males. Young males tend to get hurt more than any other population does. So we talk about osteomyelitis because it's one of the few reasons that a healthy young person might end up in the hospital or in the emergency room. So typically, a minor trauma or a sprain doesn't actually damage much, but it might open up that periosteum, the covering of the bone, just enough to leave it susceptible to blood-borne organisms getting in there. Associated very highly with osteomyelitis is this particular bug, Staphylococcus aureus. This bug lives on our skin. I mean, it's ubiquitous around humans, but it can also cause disease. So like the SA of MRSA is Staph aureus. So it's definitely a germ that's associated with us human beings. And then certain diseases predispose to osteomyelitis. In sickle cell anemia, the spleen is destroyed, and the spleen is the antibacterial master of the blood. In other words, it's always screening the blood for bacterial presence. So no spleen means higher risk of blood bacteria in the blood, which means higher risk of osteomyelitis. All right. So what happens is, this is kind of a classic abscess picture. The infection of the bone, it starts to accumulate pus, and inflammation in the bone usually results in the bone dissolving. It's one of the bone's responses to injury is it sort of dissolves, and the idea there is it can open itself up, fix the problem, and then it'll close itself back up. But if the infection stays around, then that process doesn't happen, and more of the bone gets eaten away. So this is a gross one, but this was a bone where an infection developed here. The bone ate away here and formed this big hole. This is probably distal femur that we're looking at here. So if this goes on untreated, the infection in here can actually break through into the skin. So you can have it's almost like a very, very deep abscess that actually involves the bone too. So the signs and symptoms here, local signs of inflammation. So redness, warmth, swelling, and pain, not surprisingly, in the region where the infection is. Again, not surprisingly. The tricky part in adolescence is figuring out if it's a bone or ligament injury or if it's infection. If somebody comes in and says, oh, I landed wrong on my foot in basketball yesterday, that's not going to be an osteomyelitis. If they say, my knee has just started hurting more and more over the last 2 weeks, now you start thinking infection. Yeah.
Is it going to always include breakage of the skin? Because how is the
No.
staph just present?
No, it doesn't always involve breakage of the skin. Staph can get in your blood and circulate around, and even before the staph in your blood makes you sick, it can seed other spots.
Okay.
So it can cause infection in other spots. Because this is a serious infection, you get systemic signs. So, typically the patient's not going to feel well if it's an osteomyelitis. That's another way you can tell if it's musculoskeletal or infection. If they're otherwise fine, their picture of health, it's probably not an osteomyelitis unless it's an early one. Treatment of this is hard, and that's because it's hard to get drug into the bone. And because bone is very vascular inside, but in the actual hard parts, the bony parts of the bone, there's not a lot of blood going through there. So we have to do big gun antibiotics for a long time. Now, in the past, sometimes patients would be in the hospital on IV antibiotics for 4 to 6 weeks. Now, we can put a line in and we can do it outpatient. So typically that's what's done. Most orthopedic surgeons will tell you at least 6 weeks for a confirmed osteomyelitis. Because what you don't want to see is it coming back. Yeah?
How come we don't infuse antibiotics directly into the bone itself?
Because it wouldn't do any good. It would so quickly dissipate because of the vigorous blood supply there that it wouldn't work. So yeah. But I mean, it's a good idea, but they do that in orthopedic surgery. Like if they were going to go clean that nasty thing out, they would paste it with antibiotic on their way out. All right. What you don't want to happen is for it to develop a chronic infection where the bone damage is undoable. If it starts to get massively out of control, osteomyelitis used to be a reason for amputation. So like in the Civil War, somebody got shot in the leg, it gets infected, osteomyelitis, the infection starts to spread upward. So to save the patient, they would cut off the leg. But they don't do that kind of thing anymore because we have antibiotics now. All right. This one really is, like scoliosis, this one is geared towards adolescence. This is where you see that. And that's juvenile rheumatoid arthritis, almost always just said as JRA. So it is very similar to rheumatoid arthritis in adults, but one of the big differences is rheumatoid arthritis in the adult usually affects the small joints, particularly the hands. The little old ladies that have giant knuckles and deformed hands, that's rheumatoid arthritis of the adult. For the child, JRA is usually large joints. So your knees, your wrists, and your elbows, particularly knees, come up a lot. And JRA in the child or the adolescent has systemic manifestations. In other words, fever, weight loss, lethargy, malaise, things like that. Rheumatoid arthritis in the adult usually doesn't have any systemic signs. So 1 in 1,000 kids, more common in kids 2 to 5 and 9 to 12. And JRA is an autoimmune disease. So any family that has a tendency towards autoimmune disease and the risk for JRA goes up. So like if grandma had lupus and Uncle George had rheumatoid arthritis, your risk for JRA is higher. All right. So essentially what happens here is the immune system attacks the synovial membrane, which is the part of the joint that creates synovial fluid that lubricates and cushions all the joints. So you get swelling and effusion or increased fluid in the joint. The joint is a sealed space, so extra fluid in there creates pressure instead of swelling once it's swollen as much as it can swell, and then that causes pain. Eventually, the joint cavity itself and the cartilages on the bone can start to get eaten away by the autoimmune effect. So they're red, swollen, and tender to the touch, are often stiff. One of the differences between rheumatoid arthritis and osteoarthritis, Rheumatoid arthritis is worse in the morning because the joints have kind of locked up overnight. Osteoarthritis is worse at the end of the day when the joint's been moving all day. So it's another discriminator between those two. Inflammation in joints can cause adhesions. This is where the cartilage on one bone and the cartilage on another start to get stuck together, and that can eventually lead to deformity or a loss of motion at that joint called fixation. All right. There's no specific, there's no one blood test you can get to confirm JRA. Instead, this is a rheumatoid disorder like we talked about in our immune system chapter. So, you're going to see signs of inflammation, signs of increased immune response. Any joint swelling or discomfort that lasts more than 6 weeks, you have to consider JRA because it can present with just a single joint. So you can imagine that telling the difference between JRA and an infection of that joint can really be a challenge, which is why we look at the different blood tests as well as doing imaging studies just so we can be sure that it's not an osteomyelitis but is actually JRA. And like most immune disorders, it goes up and down. It gets bad and then it gets better, and then it gets bad and then it gets better. Now, we have better and better treatments for autoimmune disorders. Here's an example where your book is decidedly out of date. We don't just treat JRA with NSAIDs anymore because the rheumatologists now have a bunch of immune modulating medicines. So basically they can turn parts of your immune system down, either through an infusion of medication or something you take by mouth every day. Methotrexate is an example of that. Now that one's considered an old one. But methotrexate slows down the immune system by reducing cell division. Physiotherapy is important to maintain joint mobility. The last thing you want for a JRA patient is for them to rest the affected joints. You want to keep them moving so that they don't bind up, so that the kids don't get deformity as a result. Prognosis here is not bad. 50% get a complete remission, and only a small number end up with any kind of significant disability as a result. All right. So let's do a question. What are common local signs of osteomyelitis? All right, I got questions all over, or I got answers all over the map here. So a key word in this question is local signs. So C, fever, leukocytosis, and malaise. While those are certainly common in osteomyelitis, those are systemic signs, not local signs. So local signs mean the area in question. Usually osteomyelitis doesn't cause deformity. Deformity is something JRA might cause over time. Pain at rest is another one that's associated with rheumatoid arthritis, not with osteomyelitis. So this guy right here is your correct answer. So a red, swollen area, pain with increasing movement. And that's because this is an active infection in an otherwise healthy bone. So when you go to move that bone, there are pressures and forces put in that on that bone, and that causes it to hurt because it's swollen and it's inflamed. And joint swelling, limited movement, JRA again, rheumatoid arthritis, or what we call a septic joint. A joint cavity can get infected just like anything else can. And I know we didn't talk about that, but that's what joint swelling and limited movement would be. All right. Oh, we're not even close to being done yet. Oops. Okay. Eating disorders, I know we're going to go through some of these because I know you've heard a lot of this before. So anorexia nervosa and bulimia are the two most common eating disorders. In anorexia nervosa, the patient just doesn't eat, usually because of an invalid or incorrect body image issue. They think they're fat when they're actually very, very thin, so they have a tendency to just try to get thinner and thinner and thinner. And all of these symptoms or syndrome of malnutrition is what these anorexics end up with. You know, so the list here: vitamin deficiencies, electrolyte abnormalities. It can eventually affect cardiovascular function, although oftentimes by then they're in the hospital. Anorexia is notoriously hard to treat because the problem really isn't with the patient's body, it's with the patient's mind. So you have to, it's hard because you either have to convince them, change the way they think about themselves, or you have to follow their every move to make sure that they are in fact eating, because they'll go to extremes to not eat. Bulimia nervosa is binge eating and purging, and they often have a normal weight, but the constant vomiting upsets their electrolyte balance. It can destroy their teeth, the mucosa of the esophagus and the mouth. All right. Acne, I think many of us are very familiar with this on a personal level from when we were teenagers, but there's two main types of lesions. The comedone or comedone is the whitehead or blackhead. These don't have redness and swelling attached to them because they're not inflammatory. They're just clogged sebaceous ducts that have ended up with some epithelial cells and bacterial cells worked in there. The other does involve inflammation, and these can become these. And the infection then of that hair follicle or sebaceous gland, it forms a small abscess basically, and oftentimes it will rupture. You know, the zit will pop. That's a small abscess rupturing. Treatment predisposing factors is always worth looking at. If the problem is elevated androgen levels, which happens in a lot of girls, and particularly during the puberty years, that can sometimes be addressed with low hormone birth control pills can help girls to clear their skin. And then you have to avoid anything that occludes or blocks hair follicles or glands. You want to keep the pores open, basically. So you avoid oily products. You want to have light cosmetics and things like that. Frequent cleaning to keep those pores open. And then there are a number of medications that we use. The list seems to get bigger every year. But there's drying agents or peeling agents like benzoyl peroxide, that's Stridex, and retinoin, that's Retin-A. Both of those help to peel away some skin, dry things out so that those pores stay open. Antibacterial agents are used more commonly, more and more commonly, orally or topically. Usually you start topically and then go orally if it doesn't get better. The cyclines are common here, so tetracycline, as well as like clindamycin is used as an ointment. The idea being, if you can get rid of the bacteria, you'll reduce the inflammation and you'll reduce the acne. Medically speaking, the treatment of acne isn't about the zits, it's about the scars. What medical treatment is trying to do is reduce the scarring that goes along with severe acne. Because the truth is, you know, somewhere in adolescence, everybody is going to have some acne symptoms. So we can't destroy it, but we want to keep it from causing a lifetime of deformity or imperfection with the scarring. All right. And then mono. Who's had mono? Come on. Who's had mono? Just one? I'm surprised. Truthfully, you probably all have had mono by now. You just don't know that you have, because that's what happens. Most people somewhere between childhood and 30 they seroconvert. In other words, they start having antibodies to the Epstein-Barr virus that causes mono. So what does that tell us? It tells us that most of the time the illness is mild and self-limited. The only ones that come to medical attention are the ones that are more severe. Either they cause more fever, they cause more malaise, not feeling well, so they reached medical attention. Transmission is by saliva. That's how it got its old name, the kissing disease. Airborne droplets or blood, so obviously you can get these, the EBV virus airborne, so anybody can get it. Blood-to-blood infection. Organs for transplant are always screened for Epstein-Barr virus because oftentimes infection is asymptomatic. And if you're going to put this organ into a patient whose immune system is going to be turned down, you have to make sure that you're not transmitting EBV at the same time. So Epstein-Barr invades the epithelial cells as well as the lymphocytes. So B lymphocytes produce antibodies. So this is similar to HIV. Here's a virus that actually attacks the cells that attack it. So Epstein-Barr virus is an anti-immune system disease, but it doesn't result in any kind of lasting immune deficiency. Very long incubation period. So it's hard to figure out where you got it because it's 4 to 6 weeks. So in 4 to 6 weeks, you're not going to remember where you were or what you were doing, at least not in very much detail. So, and then typically people produce antibodies in response to it. So what does it look like clinically? Sore throat, headache, fever, fatigue, malaise. Classic EBV, sore throat and not feeling well, almost like a flu, but without any respiratory symptoms. You'll note that there isn't any cough, there isn't any runny nose there isn't any congestion. All that you get respiratory-wise is a sore throat. Enlarged lymph nodes and spleen. Because the Epstein-Barr virus attacks B lymphocytes, and B lymphocytes are found in lymph nodes and the spleen, we see those things. And the spleen enlargement is one of the most important clinical things about EBV because a spleen that is enlarged is more likely to rupture. And a ruptured spleen can result in death by internal hemorrhage or internal bleeding. So, as a rule, athletes and sports players, there's no contact sports until the spleen can't be felt anymore. And sometimes that can be a long time. It can be months sometimes. So occasionally in high school, it'll bench a good athlete or a student athlete because the spleen is big. Big spleen means you can't be running around getting hit with stuff. The diagnosis is made with a simple blood test called the monospot test. And if you look under the microscope, you can also find atypical lymphocytes in there that are a result of infected cells. All right. Rarely, there's a hepatitis or a meningitis that results. Either of those things are very common. There is no treatment for EBV, and it almost never results in significant disability or death. So it's really one of those where we let it run its course, supportive care, treat the fever if there is one. I think one of the things that mono is most known for is that it has a long convalescent period. In other words, you got sick, the fever went away, you got to feeling better, but people with mono will stay tired for weeks. 4 to 6 weeks is not uncommon before people are back up to normal. And that's probably because of its invasion of the immune system. Because it's attacking the immune system, the body kind of stays inflamed a bit for a longer time. So it's one of the sleepy sicknesses. If you have a patient that comes in and they complain of recent fatigue all the time, you check for mono because that's one of the common presenting problems. All right. And then because it's in adolescence that sexual development occurs, this is the time period where we see abnormalities in sexual development. So there are a couple that result from chromosome abnormalities, and because patients with these chromosome abnormalities are very normal in appearance and in examination from birth until the beginning of puberty, they don't get caught up or they don't get picked up until puberty. Klinefelter syndrome is a male that has two X's, so they have an XXY karyotype instead of an XY. And the way this presents is basically the absence of puberty at the gonads. So the testes remain small, there's no sperm production, and the secondary male sexual characteristics don't turn up. So typically this diagnosis isn't made until like 14 to 16 years of age, because there's a range of when puberty begins anyway. So they don't get picked up until they start to approach the end of that range. And then a pediatrician or a family practice doctor will say, okay, it's very strange that you're 16 and show no signs of pubertal development, and they'll send off for a Klinefelter's test. These patients can be treated with hormone therapy, but they're never going to recover their fertility. But some of the secondary sexual characteristics can be brought on by external testosterone therapy. And then in monosomy X, this is a female who instead of being XX is just a 1X. So it's similar to Klinefelter syndrome, but instead for a female. So we get no puberty basically at a late age. And there again, hormone replacement is used. And then for Turner syndrome, that can actually result in normal development, although they'll probably need to be on hormone replacement for the rest of their lives. But they have functioning ovaries and things like that. And then the last one, along with sexual development comes the potential for cancer of the now active gonads and sexual organs. So this is when we encourage young men to start doing self-examinations for testicular cancer, because if caught early, testicular cancer has a great prognosis. You lose one testy, but there's another, so your fertility is maintained. But later on, if both testes are affected or if it has metastasized, it can be a real disaster, because tumors of the gonads, ovary and testes both, are particularly nasty because they can spread all over the body. They can have a wide variety of syndromes attached. And then with the beginning of menstruation is the beginning of menstrual abnormalities for some patients. So delayed menarche just means no menstruation after age 17. Usually this is due to an abnormality in some part of the female reproductive tract, so or an endocrine problem. In other words, the pituitary never turned puberty on, so to speak, and it can be chemically encouraged to do that, so it can turn that on. So either parts of the pituitary axis, the pituitary or the hypothalamus. Another one that you'll hear about sometimes is where the cervix failed it doesn't have a hole in it, doesn't have an os. So menstruation is occurring, but the menstrual flow has nowhere to go. It can't get out. So that's something that's corrected surgically. Let's see, strenuous training. We have more and more female athletes in this age, and if they are really training hard, that can delay menarche, because hard physical exertion over a long time, like training for a marathon, will often turn the menstrual cycle off for a lot of women, so that can be another reason in your student athletes. Dysmenorrhea just means pain with menstruation. Very, very common in adolescents, because this is a relatively new thing for the uterus to be doing. The system is still sort of getting used to the hormonal cycle and pattern. So dysmenorrhea is much more common in adolescent girls than it is in young women or older women. So we treat these symptomatically. NSAIDs work well. Hormone therapy, in other words, birth control pills, can help to reduce the pain with menstruation. And then over-the-counter medications like Midol, which is a classic one, which is just aspirin and caffeine, as well as a uterine relaxant. So it basically turns the cramps off. All right. Okay, so let's do another question. An autoimmune disease that causes chronic inflammation in the joints of children. Let's see if you were paying attention. We may not get to a lot of review next time, but regardless, I'll post all my review questions so that you'll have those as a study guide next time.
And when are you going to post those in the clickers and posters?
The homeworks open up the day after they're due, so you can go back in and look at those. The clicker questions, I try to post as I go. If I'm behind, I'll go turn them on.
I have
Oh, okay. Yeah, the clicker questions show up after we use them in class. And then what was your other one? Just those two, homeworks and clicker?
review questions.
The review, you mean, I'm talking about the review questions that we were going to do, tomorrow.
Did you say you post the homework questions, like the answers?
Yep, the day after they're due, you can go back to the homework, try to open the homework again, and it'll show you everything you got wrong and all that. Okay, so that, of course, is B, juvenile rheumatoid arthritis, which most of you got that, so very good. All right, because I think at this point, it's probably silly to start the pregnancy talk. So let's just call it a day.